Hello there, it's Dr. Anthony Chang from AI Med, and very excited to have my good friend and colleague, Dr. Matthieu Komorowski, here with us this morning. And not only is he a data scientist, clinician, but he's also been literally in the front lines dealing with the pandemic. So welcome, Matthieu.
Thank you, Anthony. Thanks. It's a pleasure to be here.
Yeah, tell us about your personal perspective during this very difficult time.
Well, you know, it's been quite surreal, right? I think it's a feedback we've heard from all over the world, really, that this had never been seen before. You know, I couldn't quite believe my eyes the first time I saw wards full of nurses in full PPEs, and you had, you know, rows of patients prone. Very impressive, and I think even, you know, emotionally, it's been very taxing for a lot of people. We, you know, the mortality rates were much higher than what we used to, and this was hard. You know, seeing young people in their 40s, 50s not making it. Yeah, it was emotionally difficult, and also the fact that we didn't allow any visits, right? So all those people, they were pretty much dying alone. We sorted out some ways for families to see them in bed with you know, using tablets and smartphones, but it's just not the same, right? I mean, of course, it's been especially hard for families, right?
Yeah, well, thank you for your amazing work, and we actually have dedicated a whole issue of AI Med magazine to people like you. So tell us, as a data scientist, how have you seen the deficiencies in the system as a data scientist and a clinician?
You know, to some extent, it was we were busy putting off fires, right? So a lot of people were busy simply dealing with day-to-day delivery of care. But there's always rooms for stepping back and thinking about how we can improve processes, how we can improve the management of patients. And I think, you know, there's sort of two areas where I think data science, machine learning, whatever you want to call it, modeling could help. And one is more of kind of an organizational level, you know, try to optimize patient flows, predict outcomes at a population level, predict who's going to need intensive care, who's most going to benefit from being put on a dialysis machine, for example. And you know, we've seen some papers quite early on. There was this JAMA Internal Medicine paper mid-March that was very informative, and the signal that was found was that the age, the male gender, having comorbidities, all of that was associated with the likelihood of developing ARDS and mortality. And this kind of paper has informed clinical practice. You know, we started to modify our admission criteria based on this kind of papers. And then I think there's also room for models that actually impacted patient care directly. For example, I think a big question is around anticoagulation. What do we do? They seem to be thrombosing the lungs. Those patients, they have a high rate of DVTs, of PEs. They need more than standard prophylactic anticoagulation. So looking at retrospective case series, again, this was very informative and has completely changed our protocols. Now we give treatment dose to a lot of patients based on not very much except D-dimer levels, for example.
Well, what's new in your work with deep reinforcement learning in the ICU setting? What's the next dimension for you?
Well, my focus has been on sepsis. There's clearly overlap between those patients and patients with sepsis, but it is a bit different. We can certainly think about training new models now that we have large series of patients with COVID, and I think there's some very important questions that we could address and model using reinforcement learning. So, for example, mechanical ventilation, sedation, dialysis. You know, you could imagine that you can imagine building the reward function on survival, and then trying to optimize this based on different levels of sedation, for example. There's some precedent. There was a very nice paper 2017 by Engelhardt in Princeton, using reinforcement learning for the weaning of mechanical ventilation and sedation. And I think similarly to my research, the next step is to translate those into clinical tools, and then validate them, see if there's any actual value beyond an algorithm.
Well, we'll be very excited to have you on the faculty again this year at the AIMed ICU Day on September 22nd, and give us a preview about what you're going to be talking about. I know the world is changing, so it's difficult, but what are you going to be talking about?
Well, I'll be talking about what I've been doing lately. So the push from my lab is to close the loop, bring those algorithms back at the bedside, and it's very difficult, and that's why you have hundreds of thousands of algorithms published, but very few RCTs, for example, of using AI in healthcare. So that's what we're working on now, developing the tools, working with regulators, working with information governance, working with clinicians to develop something that's trusted, that's usable, that's reliable, and then we can test prospectively.
Well, thank you very much for being on the faculty all these years, and also thank you for your hard work right now. And please be safe and stay healthy. Thank you, Matthieu.
Thanks, Anthony. Thanks, everyone.